Hi, my name is Kelly Cleveringa, and welcome to the IBS Secrets Revealed Summit. The purpose of this is to provide people just like you who are struggling with IBS solutions and answers so you can learn how to de-bloat, you can make food your friend, and you can get your life back. And today I am so excited to have Dr. Mukta Chauhan with us. Dr. Mukta is first of all, she brings over 10 years of experience in manual physical therapy and is one of the few physical therapists in the country with a double board certification in orthopedics and women's health. This dual certification, along with her extensive training in pain neuroscience, helps her to understand her patient's issues and really gives her an understanding of their overall well-being from a more holistic standpoint. She is a firm believer in addressing health from a biopsychosocial perspective because we aren't just our tissues. She sees the whole person as the center of her practice. She lives and practices in New York City, and she sees clients all over the world virtually. And so, Dr. Mukta, thank you so much for being here.
Thank you so much, Kelly. I'm so excited to be here and talk about my favorite topic, poop.
Yes.
Yeah, it's the same person you just spoke about, and all the double board certification, but it just gives me so much joy talking about poop because digestion is so important. Our health is one of the strongest pillars, which tells us a lot about our health. So yes, very excited to be here. Thank you.
Yes. Thrilled. It's my pleasure.
Yeah.
So is it okay if I just jump right into the questions?
Yes, absolutely. Let's do it.
All right. So what inspired you to begin helping people with IBS and gut health issues?
Yeah. So just like how I said, gut health is so primary to our health. Everything, it's one of the strongest pillars that determines how a person is doing, how their health is. So I wouldn't say that was my starting point into pelvic health. I tell the story quite a bit. I was just working as an orthopedic physical therapist, and I happened to work with a woman who was having a lot of hip pain. And with all kinds of manual therapy and, just the musculoskeletal approach, her pain was just not getting better. I was kind of young in my profession at that time. So my mentors had just started to introduce pelvic health in the mix. And they just I think a course that I took maybe a weekend ago or so, they said, ask your patients questions about their sexual health or their bladder or bowel health. And I was like, wow, that's so cool. Yeah, I'm going to ask. And it's never, because these topics are so taboo and people are not comfortable. And sometimes you do not get that the way in that you could ask these questions. I didn't ask those questions to a lot of my patients, but to her, I was like, I'm not understanding what's going on with her hip. So let me see what's happening with her other part, the pelvic health, which is so close to the hip. The pelvis sits right next to the hip. So I asked her if she was having any pelvic pain with intercourse, how was her bowel health? Was she having any constipation, any incontinence and stuff? And check. And I was like, whoa, okay. And she happened to be a nurse practitioner herself. And she's like, nobody ever asked me these questions. And why did you ask? And I was like, I just learned that pelvic floor is super well connected to your hip. And I think you should see a pelvic health specialist, pelvic health physical therapist. And that's what she did. And she wrote to me a month later that she was doing all fine. Her hip pain was gone. And I think that's when it kind of really sparked that curiosity in me, where I was like, okay, I don't want to see the issues just from a musculoskeletal standpoint, as PTs are trained to do. There are so many things happening in that little central part, the abdominal and pelvic region. And I wanted to learn about pelvic health, pelvic floor. And as I was learning about pelvic floor and pelvic health, it just kind of like Pandora's box, just literally right in the center, and everything is just connected right on top of it. To learn about pelvic health, I needed to learn about respiration, breathing. I needed to learn about digestion. I needed to learn about bladder and excretion. I needed to learn about sexual and reproductive health. So it's kind of like all come together. So I don't know if I am a specialist in all, but I'm definitely a jack of all trades here as a pelvic physio. And yes, that's when, and again, like working with my main territory is pelvic pain, and working with patients with endometriosis and other pelvic floor dysfunction. They always have some gut issue alongside going on. And again, it's like, oh, no, yeah, we have IBS or we have IBD, or I've been chronically constipated for a long time. I have pelvic organ prolapse, never had any child. How did I get this? And I was like, do you have constipation? So it's like an amalgamation right in the center of the body, which is really fascinating. And all these systems are so connected to each other. And I think it just makes sense to be interested in. When I say I'm a pelvic health therapist, I don't want to only know about pelvic floor muscles. I want to know how the gut is affecting the pelvic floor and how the pelvic floor is affecting the gut and other systems. So yeah, that's my little fun story of how I got interested in this.
No, that's so cool. And I really love that you are able to connect it all together. And so, it kind of comes back to what we were saying in the bio, is that you see the person holistically. You were able to see the dysfunction going on the pelvic floor and be like, wait a minute, like it's not just a segment of the body. There's other pieces to this puzzle.
Yeah,
That's
absolutely.
cool.
Absolutely. Yeah.
So can you please give us a quick
Yes.
introduction to what the pelvic floor is and the role it plays in the elimination of a bowel movement, your poo?
Yeah. Here comes my favorite part. And I'm ready with all kinds of models and stuff. So
Awesome.
what is pelvic floor essentially? Pelvic floor is a group of muscles. This is video, right? So they will be able to
Yes.
see this as well. Okay, perfect.
Yes.
So pelvic floor muscles is a group of muscles, or as we just call it simply, pelvic floor. It's basically situated in the lower part of the pelvic bowl. Why bowl? Because it is just empty. Like if I take out my, give me 1 second. I have a better visual for this, so I forgot to put this together. So just bone looks like this. There is no structure here that kind of protects the organs that are sitting on the abdomen and the pelvic region. So these are hammock-like muscles which are sitting in that empty space that I just showed you. And basically, they have many functions. It's not just the support of the organs that sit right on top of it, but also the function is guarding pretty much the gate. What I call your anal sphincter is essentially a superficial pelvic floor muscle. The opening of the vagina, or in males, it goes up to the half shaft of the penis. So, and also surrounds the urethra. So it's kind of, it's guarding the urethra, the vaginal opening, and the anal opening in people with a vulva. And people with a penis, it's helping with penile erection as well, along with other things. And in females, it helps in clitoral erection. Yes, because clitoris and penis are basically embryologically derived from the same tissue. So they're the same structures, basically. So anyway, we don't have to go into that too much, but it's an important part of the function of the pelvic floor and why we are talking about it today. So the pelvic organs, which are the bladder, the uterus right on top, and the rectum right in behind in people with a vulva. And this is the central part is the vagina. So a lot of people think vagina is just this, like they confuse the vulva with the vagina, but vagina is this tube which connects the opening part right outside to the cervix of the uterus, and the rectum sits right behind it. So a lot of things are connected here. So when we don't have good gut health, it also affects other systems. It's so closely connected. So when people are chronically constipated, I sometimes have to ask them, do you have bladder urgency frequency, or do you leak urine? Because that's also not uncommon. We see this all the time in the clinic. Because why? If you're chronically constipated, the bladder keeps getting wider and wider. It's holding a lot of poo. That kind of pushes on the bladder, just like in pregnancy, why women are more need to use the bathroom more frequently. It's the same, that you're holding so much poo here, it pushes onto the bladder and can cause the urinary urgency frequency. And not just from the organ itself, but also the way the pelvic floor is structured. So coming back to the anatomy of the pelvic floor, it's a hammock-like structure that supports these organs sitting right on top of it. Just like any other muscles in the body, the pelvic floor contracts and it relaxes. It contracts and relaxes, just like biceps. When we have to bring, let's say, a cup of coffee to our mouth, we are flexing the biceps, and we are putting it back on the table. We are extending the biceps. We're lengthening the biceps. And that's exactly what the pelvic floor is supposed to do as well. We're not aware of the pelvic floor motion like this happening, because most of the function of using the bladder, going to the bathroom for bladder or poo, for peeing or poo, is a pretty automatic function. All you have to decide that it's a socially acceptable situation. I have an access to the bathroom. I'm going to go, I'm going to sit, and I'm going to do my business. But problem starts to happen when that automatic system is not working so well for you, whether, in this particular scenario, whatever reason the gut issues started, and it's giving rise to chronic constipation, can ultimately impact these pelvic floor muscles. So sometimes it is a chicken and egg kind of situation. So for example, the pelvic floor's nice contraction and expansion is not happening, which is required to protect and support these organs, and ultimately expansion of the pelvic floor that opens up the rectum, and that's how the poop comes out. So I'm kind of going back and forth just to explain the whole anatomy and how the entire function is affected by these different systems. So pelvic floor muscles' role is to, in order for us to go, it opens up, it lengthens, it expands, so the pee or poo can come out. When the chicken and egg situation that I was talking about, let's say someone had a UTI or someone had a prostatitis or something like that, and in response to that infection, the pelvic floor became this tense ball that it has lost its ability to fully relax and allow the rectum to open, to allow the pee or poo to come out. That could also set in constipation for people. Huh. Or on the other hand, someone's problem started from up top, that they have gut issues going on, and from this repeated straining in order to go to the bathroom can strain these muscles, and these muscles are like, okay, stop, this is too much pressure coming from top, stop it, and they go into this tense state. So it goes into this vicious cycle of tension and constipation. So coming back to the topic, these pelvic floor muscles need to contract and fully relax in order to function optimally, to support these organs optimally, and to actually do the business, which is to eliminate the pee and poo. So pelvic floor muscles, especially one of the specific muscles that we're going to be talking about is puborectalis. That's the name of the muscle. And puborectalis literally means that it's attached from the inner side of the pubic bone, which is this bone, and it goes to the rectum. So the puborectalis is basically hooking the rectum at the very end like this. So it's going to look like that's how this is supposed to look like. So if this muscle is too tense, it's going to pull the rectum towards the pubic bone, right? So it's going to pull it forward towards the pubic bone. So when that happens, this anorectal angle is increased and you cannot poop, basically. It's basically the faucet is closed. It's just tight. There is no outlet. And this is what we call outlet obstruction, or in fancy clinical terms, puborectalis dyssynergia, because when you are pushing from top in order to go, the pressure from the rectum comes down and this muscle is like, okay, I'm ready to go. This needs to come out. So the muscle needs to lengthen. So it allows the rectum to align with the anus and relaxes around it so it can open up and the poop can come out. But if it's too tense and it's pulling the rectum towards the pubic bone, which is right in the center, in the front, the rectum is not going to open up. So that's pretty much how the anatomy of the elimination works, and what is the role of the pelvic floor muscles in this whole saga.
Saga is a great word for it. I love it.
So
no, that's cool.
Yeah, so pelvic floor muscles, again, they need to function automatically. You just go to the bathroom, and like how a baby, if we have seen a lot of times, if you see a toddler sitting before they are potty trained, they're put on a seat, you'll find them squatting and doing their business in their diaper, because it's nobody taught them that that's the best position to be in, but somehow intuitively they figure it out and they go into that position. And squatting is one of those positions which actually automatically lengthens the pelvic floor. And that's why now squatty potty is coming into the picture, because it's essentially bring you back into that angle to relax the rectum and open it up. So if that makes sense. So yes. I know I said a lot of things about pelvic floor. I wanted to kind of keep it towards the bowel elimination system, but I'm happy to answer any other questions if you have about pelvic floor in general, like more anatomy. I don't know. I can go in more detail if you like. Totally up to you.
Well, I think, well, my next question is a little bit different, but it plays into it. So I'm gonna actually come back to that one.
Okay.
So let's. So sorry, I've got a tickle in my throat.
Problem. Yeah.
So if someone has been constipated for a long time, so we know in IBS, like there's multiple variations and sometimes they're mixed, right? And so let's say they have more of a constipation type and they've been constipated for a long time. What can that do to their ability to feel the need to go poo and just kind of affect the pelvic region overall?
Okay. So in general, let's just talk about the normal process of elimination and how do we know that we need to go? What's happening down there? So as the digestion starts from the mouth, goes to your food pipe, stomach, and duodenum, small intestine, and large intestine is pretty much where the poop starts to form, because the water is being absorbed back, so it can kind of get that solid consistency. And then towards the end of the colon, as we are reaching towards the descending colon, and the sigmoid colon goes into the rectum, and basically rectum is this poo collector organ, right? The rectum itself has pressure receptors inside it. Even up to, a fancy thing that I would say, let me just open this up, if I can show you. There is a line that you could see, it's called dentate line, and pretty much up to that line, we can't even tell if the pressure we are experiencing is watery or solid. Like, we don't have even that sense. So until it comes down to that, below the dentate line, that's when we can sense, oh, it's watery, gotta run. Oh, it's formed, I can wait a little, I don't have that urgency, and I can sit for a little longer or walk to the toilet, right? So the rectum is that poo collector which has the pressure sensors in it, and that's how we sense that it's time to go. What happens in chronic constipation is, because we are kind of, not willingly, but it's kind of, we're abusing the system in a way. So the lining of the rectum starts to keep expanding, because we are collecting more than we are supposed to. And because of that, over a period of time, the pressure sensors inside the rectum kind of lose that ability to tell how much is in there. So for example, I'll tell you, some people drink a lot of water and they're like, I don't need to feel the need to go. And some people they don't drink a lot of water, but then they chug the water and they're like, okay, I have to go pee. And, I have probably a small bladder. Bladder, stomach, rectum, these all are collector, they're containers. They collect the stuff, the bladder collects urine, rectum collects poo, stomach is collecting food. So all of them are they have a lot of mechanoreceptors inside, and mechanoreceptors is just a fancy word for pressure sensing receptors. And it's basically, they can adapt to a more demand. If I'm like, if I am training for a marathon and I'm like eating a lot of food, I was like, okay, I'm still hungry. I can keep going. So my stomach is distended and I can keep going and going. And then the minute I stop marathon training and I'm not burning as many calories, I'm still eating that much because my stomach can take a lot more. The same way, if I am habitually drinking more water at a consistent rate, my bladder can hold more urine. The same way, chronic constipation, the rectum can hold more, because guess what? We are making more poop, but not eliminating it. So it needs to stay somewhere. It gets hardened. That's a different story. I'm not talking about it, but the hardening of the stool also distends it, because it just keeps on collecting more and more there. So the original question was how it changes the, someone's, what was the original question? I'm sorry.
Yeah. So it's okay. It was fast. I was like, yeah, tell me more. Like, okay, so I could see how that could, like, it's like, I guess I was thinking of it almost like a water balloon, where like when you first start to like fill it up, it gets nice and responsive, and then it gets even bigger and then gets more pliable. So I guess that was what I was thinking as you were talking about it. But to answer your question, so how does this affect the pelvic region overall if you've got this distended?
So, and the urge, how do you,
and the urge, yes,
that was the original question. So obviously they're not getting that urge as well as they normally would, because it's just too distended. You put the same amount of volume in a bigger container and a small container, the pressure is always area upon volume. So if the area is bigger, you're not going to feel the same kind of pressure. It's directly proportional. So that's a little of physics there. I don't know if I needed to put it there, but anyway, I think it's helpful.
It's there.
Okay, so since that urge is also lost, what ends up happening is fresh poo is being formed. The wall of the rectum, sometimes this additional hardened stool kind of start collecting in sigmoid colon, and can even go up to the descending colon, what we call impacted stool. So because the lining is not gonna be working that effectively to absorb the water, the fresh poo that's coming, the water does not get absorbed from it. And that's why some people who are chronically constipated get this occasional diarrhea, and they're like, oh, maybe my constipation is gone.
Oh.
But it's just, and in IBS as well, the mixed thing could be, we have to check if they are not, are they really going into a very clean cycle of from constipation to diarrhea? Or is it because they're still constipated and they're getting the diarrhea because of the poor absorption now in their colon?
Wow.
So that's
Cool.
another point. Then obviously, if you have hardened stool, it's not formed fully. Instead of a big banana-like or sausage-like poo, you have like broken up, and you're like, you don't have any urge on top of it. You're like, somehow I know I haven't gone, and I've been eating. I need to eliminate. You go to the bathroom, even with the slightest urge, maybe you have a very little urge, and you're straining. You're like, okay, I need to really go, and you're holding your breath. You're going, you're straining a lot. What ends up happening? The pelvic floor muscles get all the strain. So remember, it's the pelvic floor muscles. One of the functions of pelvic floor muscles is to accommodate the pressure coming from top. So if the pressure is coming, it expands to kind of catch that pressure coming from above, just like a trampoline. If you could see, like a bulkier person jumping on a trampoline would go deeper, and a lighter person wouldn't go as deep because there's not enough pressure on the trampoline, right? So the same way, if you keep on putting that big pressure on your pelvic floor, it's going to give at some point, right? So it can do two things. One, it can push back and tense up, tighten up, like, no, I got to be more prepared for this upcoming pressure from above. So I better be prepared for it. So it's going to go into this guarding, tense up all the time. Or it's going to be like, I can't, I give up. And these are the people who either have incontinence or who have rectal prolapse, because the elasticity is just kind of ruined, you know. So if I where is my, not ruined, that's a strong word, I don't want to say that, it's not like you can't get better. I lost my elastic band. Oh, right here, it's right now. So like, if just like an elastic band, if you keep on stretching, it loses its elasticity at some point, right? So it's the same idea, because muscles also have a lot of connective tissue in them, and this connective tissue is the one that gives, you know, it reaches that failure point, and then it cannot come back to the original position. So if I stretch this band, it can come back to its original position. But if I keep doing this over and over again, it won't go to the original position. It will stay stretched. So that can also happen to pelvic floor muscles and the ligaments that connect the rectum to the bony pelvis. So that's the overall consequence of constipation to pelvic floor and the urge issue that you were asking.
So now I have two questions. Number one, my first question is, okay, so if someone's listening to this and they're like, ooh, I may have stretched out my rubber bands, is there a way to retrain it and strengthen it back up?
Absolutely. Research has found that muscle strengthening can actually build back the connective tissue and make it more tensile. You know, this tensile strength is basically how much stress and tension it can resist any tissue in the body. So as you are putting more and more stretch and stress on these muscles and ligaments, they're definitely going to stretch out. But again, it has the ability to come back. There are many factors based on which it's going to improve: your age, your comorbidities. For example, no, different, like obesity could be one of the things that could be little challenging because there's a lot of pressure on the pelvic floor to begin with. Pregnancy, for example, is for the same reason is challenging for pelvic floor muscles because there's a lot of pressure that's coming from the abdomen region over on these muscles. So it's not like it's irreparable, nothing can be done, but these are some of the things that we need to take into account and work accordingly when we are doing exercises with these patients. A lot of times people may think that they are leaking. For example, fecal incontinence can happen with urgency. Like sometimes that urge is there when people with IBS, like they have to run to the bathroom. And that usually happens because of impacted stool also, that because the diarrhea come gushing down and there is no water absorption happening through the walls of the colon, and the anal sphincter is not strong enough to keep holding everything, and it's like, okay, I give up, and it just, there is some incontinence can happen. So we also have to see if these muscles are super tight or they are super lax, and then we have to kind of make a plan accordingly. So for super tense muscles, we have to help them release. And then once they're released, then we do get into the strengthening protocol. But again, not everyone with IBS needs strengthening. It's more of a synergy that we teach to them to be able to go. I haven't come, I mean, it's not unheard of, but it can happen, especially in older people. Age is another reason that can cause more weakness in pelvic floor muscles and stretching of the connective tissue. So if there is an older patient with IBS, strengthening may be required for them, but I haven't seen that in my younger patients.
So with the youngers, so I guess you said the word synergy. Can we come back to that? And what do you mean by synergy?
Yes, I will talk about that. So automatically, the automatic response of the system body is that whenever there is a pressure coming from above, the pelvic floor is supposed to tense a little in order to give back, just like a trampoline. If trampoline was just like not elastic, you would just go down without that bounce up, right? So pelvic floor is basically that trampoline. You push, you kind of like, the pressure from above is coming down, and the pelvic floor is like, okay, I need to contract so I can push the pressure back up. So it's like an accommodation that's happening. When I say synergy, it's basically the synergy. There are two synergies I'm going to talk about. One of them is the diaphragm. Let's talk about that one first. So diaphragm and the pelvic floor work together. The diaphragm, as you inhale, expands and come down. And as it's coming down, it kind of displaces the abdominal organs outward and downward. And that's why we see our belly rising with diaphragmatic breathing. It's not that the diaphragm is in the belly, it's because the diaphragm is displacing the organs downward. And then you have the pelvic floor, which is right below, taking up the pressure from these organs. So diaphragm, with inhale, the diaphragm comes down and the pelvic floor comes down as well, because it's accommodating the pressure coming from above. So, and as you exhale, they both move up. So you're basically, this is the synergy that happens with the diaphragm, which is another important muscle for digestion. If you're not breathing very well, if you have tension in your belly, digestion can be very challenged because of that. But if you don't have a good pelvic floor flow of this contraction and relaxation, that can also, in a backward feedback loop mechanism, can affect the diaphragmatic movement as well. Because it's like, I'm tense, the abdominal muscles are like, okay, we'll be tense too with you. And because the abdominal muscles are tense, then diaphragm is like, I have no room. I'm going to be like frozen in space like that too. Or if you don't diaphragmatically breathe and you have a lot of tension in your upper body, you're a chest breather, your belly, like I mentioned before, you're super tense there, your pelvic floor is going to be tense as well. So this is one synergy which helps with the digestion and flow and helps with venous return, like the blood flow coming back to the heart is happening because of this pressure change, because of the diaphragm and the pelvic floor. Lymph flow is also happening because of this. Super exciting. It's one single muscle with
Yeah.
diaphragm. You can do so many different things. Mind blowing. The other synergy I was talking about was how do you go? How can you teach the puborectalis to not tighten as we are pushing from above and actually help expand? So if you automatically, the way we are wired, neurologically speaking, if you're going to cough or sneeze or lift something heavy, anything that would increase the abdominal pressure is going to tighten the pelvic floor. Why? Because we want to stay continent. We don't want to leak when the pressure increases in the abdomen. So but to go to the bathroom, we have to sometimes strain to increase that pressure from above to propel the things forward. So if I'm increasing the pressure, it's a direct neurological wiring to tell the pelvic floor to tighten up. And if it's tight, how is the rectum going to open? So this is what happens in puborectalis dyssynergia, which is a fancy word to say like puborectalis muscle is not working well with its good synergy. So so that's why we teach people to not go by straining. So instead of doing, we say, make a sound and vocalize and say maybe moo. So when we say moo, we are engaging the top abdominal muscles, not the lower ones, because lower ones have a direct connection with the pelvic floor. If lower ones are activated, if you're creating tension in your lower abs, your pelvic floor is going to contract no matter what. But we can, with this vocalization, activate the upper part of the abdominals and keep the pelvic floor more relaxed. So when you say moo, you're creating that tension. You can try to say this,
Yeah, I
and
can feel it. Yeah.
you'll feel the
Moo.
tension
Yeah.
in the upper abdominals, and the pelvic floor will expand. So this is part of one piece of teaching or rehabbing for chronic constipation or outlet obstruction or puborectalis dyssynergia, how we help teach expansion of the pelvic floor muscles. So this is the synergy I was talking about. I can talk about it more, but feel free to ask any questions if you have.
Yeah, well, I just want to reflect on that really quick. So, I think that mooing, and I know you mentioned this and I forgot about it, but you called it moo. Wait, moo for
Moo to
poo.
poo. Yeah.
I just love that. But that's like a really good to kind of go back to that diaphragmatic breathing, which in an earlier video we were taught. And so, for someone who hasn't done that for a long time, do you feel like starting to do that mooing? And or at least if you're afraid to like sound like a cow in your bathroom, whatever, like I'm sure there's a similar sound you can make. But
it's all about just grunting or like creating this, just like how how you've seen the heavy lifters, they always like they do this kind of a sound. So the vocalizations are different ways of engaging the abdominals. This one is particularly important for people with constipation or lack of urge or lack of that feeling of pressure. So they don't end up clamping down on the rectum at the end, and they can actually expand, open up the pelvic floor so things can open up and things come out. Basically, that's the whole idea. So
yeah. No, that's so cool. So
it's 5:00 and I'm just noticing.
So we'll wrap because I know you got to go. So we're gonna wrap this up.
I can talk a little more. I can just let this person know that I'm running late. If that's what you want, it's totally up to you. I don't know.
Well, I feel like we covered a lot. We definitely talked about the constipation piece. We covered the mooing for pooing, which
I think we did talk about elimination. So it covers all these things. So I can quickly go and talk about, so sometimes what we do is to help with the urge. We call this a balloon manometry. If people have had dyssynergia or they have been given this diagnosis, they must have heard of balloon manometry. This is basically, I'll just show you quickly. It's basically, we take the air out of the balloon and insert it into the rectum through the anus. It's not painful, I promise. We put a condom on it, we put it in, and then we slowly increase the pressure until the person starts to feel the pressure. And then we ask and teach them, can you practice this mooing and expel this balloon? So they're like, no, nothing is coming out. Like, no, change your strategy of maybe, then we try to do different kinds of breathing exercises with them to teach them how to do this in a better way, basically. Yeah.
So just because I just have this image that people are gonna be like, you're going to put a balloon where? That's not necessarily where you have to start if you're like starting to go down this
Absolutely.
journey. Okay.
And that's where the free gift that I created for this summit is going to talk about that. It's going to talk about how to find your pelvic floor muscles, find how to connect with the pelvic floor muscles, how can you figure out their function. And there is another device, again, like there are many ways. I have listed all those ways in the free gift. And this is a pelvic wand. And if someone has a lot of tension in their pelvic floor muscles, we also teach how to use a pelvic wand to relax the pelvic floor muscles. It's almost just like how you would, it sounds weird. And if you've never heard of something like this, but I always say, like, would you find it so weird if I say you have tight hamstrings and these are the stretches of the hamstrings? The problem is the pelvic floor muscles are sitting inside, so we have to reach them some way. You can even use your gloved finger. So I have written down all these different ways of feeling the tight muscles and working on them. And let's not forget, pelvic floor muscles have a huge role in digestion and elimination. And most of the times the diet and lifestyle and other things are blamed for it. But hey, these are the muscles that could be easily, not easily, but they're in your body. So you can connect, you can learn to connect with them. You can cultivate this awareness, stretch them, do multiple stretches. And yeah, you can help yourself get rid of some of the pelvic floor dysfunction issue, which could be causing your constipation.
Yes. Thank you for tying that all in. I'm sure because some people were like, wait, what is, but yeah, you're right. If you've done diet and you've done all these other things, but you still feel like there's a piece missing, yeah, absolutely. This could be a big part of what's going on. And so, yeah, download that free gift, like check it out. You've literally nothing to lose. So yes. So Dr. Mukta, thank you so much for being here and for sharing your knowledge and your expertise and your passion. Like, I just love seeing how excited you get when you talk about this. And so thank you.
Yeah, thank you for having me too. It's always, I love educating about pelvic health because it just, again, I mean, we all have this. And, I just learned about these muscles when I was, 32, and it's like, hey, I've had this all my life. Why aren't we taught this earlier in life? We could, prevent so many different conditions from happening.
Yes. Yeah. Well, this is how we start, right? We start like
absolutely
pulling back the curtain.
Yes. Quite literally here.
Well, thank you again. And I just want to thank the listeners. So thank you, listeners, for being here. Come back tomorrow. We still have more goodies for you. So thank you for being here. Dr. Mukta, thank you so much. And we will see everybody tomorrow.
Yeah. Thank you, Kelly. Have a wonderful day.
You're welcome. Thanks, you too.
Bye.
Bye.